This is a great group of panelists that we have here this morning to discuss reimbursement. With that, I'd like to introduce the moderator for this morning's session, Roger Longman, who's the Chief Executive Officer of Real Endpoints. Roger has spent nearly 30 years in the healthcare industry, most recently as the Managing Director of Pharma at Elsevier Business Intelligence, a Reed Elsevier company. So with that, I will turn it over to Roger.
Thank you, Celia. And thanks for coming to this. We're just going to start with a few scene-setting slides. I just want you to realize that we're going to be largely talking about the health impact, the economic impact of specialty drugs. And just so you understand, most people do not recognize just how big the how shall I say it, the drug cost problem is. If you look at most presentations from insurance companies or drug companies, you'll see that drugs are sort of 10 to 15% of the total spend. In fact, if you actually look beyond what's called the pharmacy benefit, you'll see a lot more dollars spent on drugs. It's just not particularly well controlled, and it's not particularly well counted. I mean, if you want these slides, you can get them, I'm sure. The point is that the biggest and fastest growing problem, I would say, actually, in terms of healthcare costs, fastest growing problem, is the specialty drug side. So here, we're just showing some growth in parts of the industry, total healthcare costs. That's probably my daughter. I'm sorry. No, yeah, she is calling. Any event, you can see that the total healthcare costs are projected to grow moderately. Traditional drugs are projected to grow very little, but specialty costs are growing, kind of in the 20 to 25% range pretty soon, which means that if you look at the total drug spend, that's the blue, a good part of that is now specialty, and a big part of that, like 30% of the total drug spend, is going to be specialty drugs. We'll get into trying to define what the hell specialty drugs are, because I don't think anybody really knows. But why is this important? It's important because the world is changing, and that's what this panel is about. I'm not going to go through all of this with you, but I just want to point out that the definitions of the key actors in the world are changing. So from payors, you are changing from sort of the indemnity world. I mean, I'm not against insurers, but largely they were credit card processors. And they're now moving into something else fairly dramatic. They're actually going into risk sharing, and they're becoming providers, as providers are becoming payers too. Physicians are going from sort of self-employed free agents, fee-for-service incentives, to actual employees, and they are going to be aligned with their employer's objectives. Product launches, if you think about it. They're going from what you might call the Mevacor or Lipitor kind of launch, where everything was you tried to get to as many people as possible, to what you might call provisional and incremental kinds of launches. The unit of value, particularly cancer, this is interesting, the unit of value used to be the single product. I think increasingly it's going to be the pathway. So the product within a whole set of products. Pricing, what was the value to doctors, to patients, neither of whom cared what the price was, to the value to payers. And ultimately, I think, too, something else we need to talk about, evidence. Who did you give evidence to? You gave evidence to doctors, the kind of evidence that would incentivize, that would convince a doctor. And now you give it to payers and payer vendors like PBMs and so on. So with that brief introduction, I'm going to go sit down now and talk to my panel. My panel is Peter Bach of Memorial Sloan-Kettering, and a very, very smart health economist as well as a physician. Cynthia Smith is with Affimax, and she runs managed markets for them. And Rena Conti, who is at the University of Chicago, a health economist at the medical school. So I'm moving over here. Also, please do, if it's all right with you guys, I haven't actually asked, but please do interrupt with any questions you want to interrupt with. It's all perfectly fine. We're all adults here. So let's start with first question. Who drives the uptake and the use of specialty drugs today? And who's going to drive it tomorrow? You want to start, Peter?
Sure. So thanks for having me. And while I'm answering, do you want to call your daughter back? Or?
No, I don't. She'll live without me.
Okay. So, there has been, you've captured it well on this slide, there's been a substantial shift in the route to market access for specialty drugs, particularly in cancer, but in a lot of these physician-administered drugs, because payers are increasingly sort of upping their intelligence around utilization and trying to insert either third parties. You mentioned PBMs, but we have analogies in other areas of service utilization. Companies are stepping in, pathway companies is a version of that. We're managing utilization, managing access. Some of the traditional radiology benefit managers are trying to get into the specialty drug space as well with separate modules. And so in the old days, if you will, meaning 2 years ago, doctors would sort of make decisions partially based on evidence, partially based on sort of profitability and things like that, try to be a leading edge and advertise on that as well. And there were very little in the way of checks. Payers were at best afraid of getting into that space, and mostly these things were, like you said, credit card processes or pass-through payments. And there's no question that we're seeing emergence of sort of control. And what's intriguing about it is it's coming from every side, but it's all sort of the same beast, right? So there's a private sector kind of pathway companies in oncology and very tight or tighter management of particular utilization from one side. And then there's a sort of public sector, through ACOs, through sort of demonstrations. They're starting to look like ACOs, whether it's expansions of PGP or BPCI or any of those other efforts that are shifting risk to some other entity that, again, should have somewhat more intelligence than just the pass-through payer around utilization. And they're all seeking ways to get these very small segments of their delivery system, like oncologists or orthopedists or cardiologists, to behave in a way that's net cost saving. And so they're trying every sort of approach they can. So UPMC is this great example of them pushing out pathways within their system to reduce
UPMC, just so you know.
Sorry, University of Pittsburgh Medical Center. Yeah. Sorry. But anyway, so that, so there's, I think that's where we're headed. And for sure, many people in the industry, whether they're device or drug manufacturers, are asking these questions. What do I need in 3 years to get this on the market? What are payers going to expect? That's the hardest prediction they're trying to make. And for sure, 10 years ago, 5 years ago, that wasn't even a question. It was just, what do I need to get the FDA to approve this? Because I know the rest. I get KOLs, I show up at ASCO, I have a couple abstracts, I'm golden.
Well, give me your thoughts on this, and then let's turn to you, Cynthia, to see your practical results.
So I think that in the past 5 to 10 years, we've shifted from really demand-side control, where it's really individual physicians or physician groups managing what they're going to be giving to their patients, to really shifting towards insurers or really medical groups making decisions about what the pathways are that are going to be what they're going to be giving to their patients, both in first-line and second-line therapy. It used to be that NCCN guidelines would, for oncology, really drive a lot of market share, but it's clear that it's not just guideline-based care now, but it's also value-based care that payers in particular are becoming very focused on. Just to give you a quick example, I work in a hospital that has a very prominent oncology group, and when I survey our oncologists, they say over and over again, I'm spending more and more time on the telephone talking to the insurers of my patients to make sure I can both write the prescription that I'd like to write for the oral chemotherapy or the oral adjuvant therapy, but also write the order for infusion of chemotherapy. The only other thing I would like to mention around that is that the FDA in recent years has become a lot more stringent. They are clamping down both on the final product in terms of demonstrating quality, but also they're ramping down or clamping down on the quality of production facilities. So you need to be anticipating both payers being focused on value, but also regulatory agencies being focused on you meeting certain quality endpoints in the near future.
Cynthia, what's the practical result of all of this? Have you had, you're in the, I guess you could be said to be exactly in the crosshairs of everything, given that erythropoietin has been,
Sure.
Erythropoietin stimulating agents, which yours is one of, are in the, have been damaged, let's put it that way, by a lot of stuff now.
I think that you can, by tracing over the past 10 years, the change in the ESA marketplace, you can sort of see how things are going to evolve into the future for other products, I think. I think it's sort of a forebearer. But I would say that, where it's interesting for a company who's interested in drug development is that we're trying to predict who that value decision maker is going to be by the time that the drug gets to market. And that's evolving so quickly it becomes more difficult. So while 10 years ago people were very focused on the physician, now the value equation is very much focused on the payer. A few years from now that may be now pushed, that risk and that value may be pushed back down through the ACO model to the institutional provider who's going to have an aligned interest with the payer. So I think that it really does.
And the ACO model is going to have an aligned interest with the payer because theoretically the ACO, the economics of the ACO, is partly to do with whether it is in fact meeting economic objectives as well as quality objectives.
Exactly, and when you look at value in a very contained, say just in oncology or just in the renal space that I work in, it's maybe a little more limited. When you move to an ACO model, you actually have to demonstrate value in a much broader setting. You have to look at what hospitalization costs are and how your drug works with hospitalization costs. You have to look at other therapies and what the whole patient care. And I think that's going to be a huge change for pharmaceutical companies moving forward.
Let me move actually into one specific example. Peter and a colleague of his, a couple of colleagues of his at Memorial Sloan-Kettering did something I think completely new, at least in my experience, and that was at Memorial Sloan-Kettering, they kicked a drug off of the formulary. And the drug that they kicked off was a drug called Zaltrap. So Peter, can you tell us, one, what was behind that? It's a new drug from Sanofi Regeneron. What was behind that? What caused you to do it? And what do you think the implications are? And I'd like actually Rena and Cynthia to comment as well.
Sure, so the story, thanks for asking. The story is actually exactly as we described. We wrote a piece in the New York Times where we said exactly what happened. Our formulary committee evaluated the drug head-to-head with an alternative and second-line metastatic, same mechanism of action, Avastin at 5 mg/kg every other week, and which is the standard dose, and decided that looking at both efficacy and toxicity, that Avastin was the dominant strategy. We had more experience with it. If anything, the side effect profile looked better. The administration times were somewhat shorter. And there was no efficacy benefit of Zaltrap, and then we priced it out, both in the private markets and Medicare, calculated the copays for our patients, and came out with the conclusion that the copays were about 2x for Zaltrap compared to Avastin under most plans, and decided not to use Zaltrap. And that was sort of the full story, and we described it, all of those calculations, and basically lamented the fact that we were put in that position, that no one else sort of would step in. And I understand, we used to work in Medicare, I understand why it is that neither the FDA or Medicare or any private insurer would step in, but it was nevertheless, we felt like that was an easy call. I'm actually very curious what other people think about the implications. I think one of the mistakes, or one of the challenges about discussions like this one, or
Can I just interrupt for one second, Peter?
Oh, please. Yeah.
I just want to stress one thing. In oncology in particular, it is vanishingly rare to see an institution say that a new approved oncology drug will not be used in that institution. I can't really stress to you just how radical a move that was. I'll also point out that it was physicians doing it, not payers. But in any event, I just wanted to stress that.
You know, we're not totally naive. You know, we pitched it to the Times because we knew it, or we anticipated that it would seem unusual or would seem bold. And actually, the feedback was largely that it was sort of bold. But that's right. You know, the days of it's newer, therefore it's better, we were sort of announcing were over. I think that's overblown. It's probably not over at all. But anyway, that was sort of our take on it. And that this, you know, what's challenging if you think about healthcare policy and spending is this idea, this tension, and we articulated this as well, that any rational decision you make to not use something that's expensive is reframed as rationing of care, which is somehow bad in this country, right? So we want to emphasize as well that, you know, we can make reasonable decisions that are in the best interest of our patients' health and still financially advantageous to them. And the truth is we lost, you know, we'll lose a little bit of money through this decision as well because our margins are better on more expensive drugs. I mean, it's probably a trivial thing for us. But nevertheless, it's, you know, that we'll see if other people follow. Some other institutions, we immediately heard from other institutions that they were going to take the same move, or they're going to sort of do it in back channels. Some large physician networks said they weren't including things in pathways, and pathway companies have started to be asked about this as well. And as everyone in here probably knows, Sanofi instituted a rebate program that would lead the price, the net price, at least on the doctor side, to fall, and that'll eventually go through the ASP system.
Let me just point out one thing. In case there are words here that you are unfamiliar with, such as the pathway companies, we'll be happy to define those. If you don't know them, just raise your hand, because I'm not sure what the level of understanding is. Rena, let me just ask you, given what happened at Memorial, is there likely to be anything felt by, from reimbursement-related organizations such as pathway companies or directly by payers to this kind of a decision? And will it happen in other areas, that is to say, payer-driven?
So I think there are two interesting things for me about the Zaltrap story. I think the first is, notice what Peter Buck said. He said, we cared about the side effect profile, and we cared about the other types of ancillary costs, both in terms of patient health, but also in terms of internal cost relative to the next best option, Avastin in this case. I think demonstrating indirect benefit, which is both about side effect profiles, cost savings, or efficiency gains for not getting people back into the hospital, is going to be very important moving forward. So it's not just about the efficacy of hitting an end target. It's about all the other indirect value that matters here, because you have smart, savvy doctors and P&T committees who are sitting there comparing what the next best option is. The second is about the copayment amount of Zaltrap. Doctors are increasingly on the front line of having the conversations with their patients, again in oncology, but in other places as well, about how much is it actually going to cost the patient to undergo the therapy that the doctor or the pathway, in combination with the pathway company, recommends. There's a very recent Genentech review on the oncology space where companies noted that they're increasingly being asked to help with copayment support for patients, particularly insured by Medicare. Is this in your experience as well?
A little different situation, but yeah, sure.
Right, and so again, doctors on the front line of both trading off the value proposition, but they also have to go talk to the patients and their families about how they're going to pay for it. So they're going to become more sensitive about what the copayment amount or what the patient upfront payment is going to be.
What's the effect been on you? Any?
Well, absolutely. I think it's important to sort of understand the reimbursement environment that my drug launched into, which in 2011, CMS, who pays for 80% of patients on dialysis, which my drug serves, went to a bundled reimbursement system, which is essentially a prospective payment system or a fixed payment for all dialysis care. And that includes injectable drugs. So no longer was there a cost plus or ASP plus 6 environment for these products. And you, in that environment, actually go straight to the dialysis provider.
Let me stop you for a second, since just so we can level set.
Sure.
Most specialty drugs, infused drugs, are paid on what's called an ASP +6, which is to say the physician buys the drug and he gets reimbursed by the payer for the price of that drug, sometimes with a little margin, but he is also given a 6% infusion fee. The 6% is based on the price of the drug. If a drug costs $1,000, he gets 6% of $1,000. If the drug costs $100, he gets 6% of $100. Which drug is he incentivized to provide? Obviously, the more expensive drug. So,
exactly, and Peter actually alluded to this. So in the world that I am in, which I actually think is a precursor to many of the things to come in the reimbursement world, we are competing head-to-head on value with the institutional dialysis provider. So it is about cost, it is about operational efficiency, it is about the impact of the drug on their other costs, and it is very, very real. So I think it's the world to come, and I think we have felt it, and I'm not surprised that Peter is making these kinds of decisions. I think we'll see it more and more.
Let me move on to another question, and that is, who's actually doing the kinds of assessments of these specialty drugs, the kind of assessment which results in a sort of a Zaltrap decision? We've got, if you think about it, the federal government involved in a significant way in outcomes research or real-world evidence research with groups like AHRQ. I can't even remember what it stands for. Something.
Agency for Healthcare Research.
Thank you. PCORI, Patient-Centered Outcomes Research. Who else have we got? Federal government.
NIH.
NIH, yeah.
Meaningful slice.
And then we've got insurers. The Blue Cross Blue Shield Association has something called the Technology Evaluation Center. There's a thing up at Harvard called ICER, which does a few things. I'm sure there are others. So I guess the question, who's doing the technology assessments? Obviously, Peter, you did the one on Zaltrap, but there are dozens and dozens and dozens of drugs, and that's just oncology. Where is this technology assessment going to get done? Who's going to do it?
Yeah, so it's a great question, and as a researcher, I hope lots of people who does these things, I hope lots of people want to fund massive studies like this. The truth is that so the reason we wrote about Zaltrap, one of the questions immediately was sort of what's next, and the answer was everything. But the reason we started there is it was one of the few we could explain in 800 words. Right? It gets infinitely more complicated when you're comparing regimens, when there's different sort of dimensions, which some are better, some are worse. But I actually want to challenge the notion that any of this stuff matters. Right? Not our article about Zaltrap, but tech assessment. And the reason is that the latest moniker in healthcare is value. And it's aided by the fact, like all monikers in healthcare, that nobody can define it, so everyone gets to claim it. Right? So if you look at, for example, in the oncology space, these pathway companies, these intermediaries, and the same with either payers acting alone or with some third party, or even payers contracting with doctors and doctor practices to practice in particular ways, there's a veneer that there's a tech assessment in place. But the truth is, in the old days, it was dominated by the doctor-drug company relationship and the profitability of that, and the payers sort of stood back. And now it's dominated in the bundled environment, or even in this sort of contracting environment, by the payers and the doctors, sort of working to save money. And if you call up some of these private sector pathway companies, and I don't want to set us aside, but obviously the Zaltrap thing there was in black and white. That's what we were doing, and that was why. Right? If you call up these pathway companies and say, can I see your pathway for metastatic non-small cell lung cancer that you're selling to this insurer that this practice has agreed to follow, and somehow you're an intermediary and who's paying you anyway? They'll tell you it's proprietary. And so my question is, and they'll say, oh, well, it's extracted from NCCN guidelines, or it bears a resemblance to NCCN guidelines. And if you look at NCCN guidelines, they don't tell you what to do. It's sort of a buffet right when it opens, right? Every possible choice is listed there. No one else is standing there, right? You can pick as you want, pay by weight, right? So that was a joke, boy. It's a buffet illusion. Anyway, The important element of that is that there's no reason to presuppose that those pathways are driven by value no matter how you define it. What they're probably driven by is the cost savings. So that alignment of interests isn't driven by tech assessments that are highly granular and carefully sort between this regimen versus that regimen, preventing hospitalizations or not. These sort of direct cost kind of approaches, all proprietary. And I don't have any reason to believe these pathways are providing kind of the greatest benefits to patients. I just assume that they make sense to somebody with a green eye shade and can kind of be argued for because somehow they can be found in the NCCN guidelines, which is a list of everything ever used in any cancer.
Yeah, let's just sort of, for example, let's define what the NCCN guidelines are, or in fact, actually what guidelines are. Guidelines are not necessarily what's the best therapy out there. Correct? Why don't you just tell us?
Oh, so the NCCN guidelines, it's true of other guidelines as well, are a consensus-driven process where essentially they've tried to address every major cancer type and every major cancer scenario. So they are comprehensive. They're generated by these NCCN, or National Comprehensive Cancer Network, member institutions. Sloan-Kettering is one of them. Is Chicago one of them also? I can't.
Yeah, Chicago.
University of Chicago, there's 21 in all. Right? Major places, Dana-Farber, MD Anderson. And what they list is essentially the union of all possible therapeutic approaches for each of these cancers. So the example I've made a lot of hay out of is first-line metastatic non-small cell lung cancer lists 8 different regimens as appropriate. Adjuvant breast cancer, node-positive disease lists 27 different regimens that you could use. So you can't open the book and figure out sort of, it's not a cookbook where it says, okay, you have this person use this therapy. It's not even granular enough to say, well, use this therapy, but if they have an allergy to this, then use this other therapy. And so they're not sort of finely focused. They're, even though the word guideline would suggest that it would lead you to a particular approach, they're instead, if you will, an amalgam of all possibilities that anyone would deem reasonable. In fact, their process is a consensus building process. There's lots of horse trading that goes on. And they now have authority through the regulatory process and a set of laws that if they say something is appropriate for a particular cancer, Medicare has to pay for it. And so now, because of that, that's recent, the last couple of years, now as they develop these guidelines, in the back of everyone's mind, or in the forefront of everyone's mind, is if we don't list this, then Medicare won't pay for it, and then private insurers won't follow suit. And so it's heavily influenced by the fact that their decisions essentially allow for payment of the things that they recommend.
So Rena, who could do tech assessment that would be fair, objective, smart, would encompass the economics as well as the medical benefits of a particular product? Who can do that?
So fun people like me, right? Geeks. No, so I mean, there is an industry of health economists who do this type of tech assessment. They have become more prominent in decision making in places like Canada and the UK that have direct guidelines where health economists in a process with physicians and other people make recommendations, but who also negotiate directly for prices with companies.
Which is to say they can't exactly be objective.
That's right. That's right. So there is a group of people like me who work for guideline or guideline companies, but also increasingly computerized tools that help guide decision making for physicians. Interestingly, the latest evidence on the use of kind of these type of systems that you have on your phone or you have on a tablet and help you guide your treatment choice show that they are actually really there to maximize value or revenue generation for the medical groups or for the hospitals, and not necessarily providing value for, let's say, the ultimate payer, maybe Medicare. We don't have one institution in the US that does technological assessment and who provides fair and objective viewpoints that have really Medicare's perspective at heart. And my read of the tea leaves is that we're not going to have an independent body that, that advises Medicare on these issues in the near term?
Actually, I do think that there is a technology assessment that is going on constantly, all the time, and is probably the single most powerful tech assessment movement. And that is also the oldest tech assessment movement, and that's frankly the P&T committees of roughly 1,000 plans, several thousand hospitals. The question, and those are probably also the most influential technology assessment groups. Problem there, and I guess I'd like the panel to come in on this, are those assessments being made in any kind of objective, consistent, systematic, clear way in general? What's your thoughts? First of all, do you agree with me about P&T committees in general?
In the specialty drugs, I think it's consistent with the other comments that, in the specialty drug space and in the sort of intense spending areas and diseases, I think there's a trend towards P&T committees becoming more active. Many of these insurance plans, and now we're obviously talking about private sector insurance, are regulated by the states in which they practice, and they're pretty hamstrung in terms of what they can do, because they're required, for example, to include drugs are approved by the FDA for any serious illness and things like that. But
remember, when you can include a drug on a formulary, that means that you can include it as a preferred drug or a less preferred drug. You can put it in a higher tier or a lower tier with more and more restrictions and so on. So
no, absolutely, right? So we are seeing things like that. It's unfortunately, I think, too closely linked to the unit price of the drugs as opposed to things like value. And I do think that there are situations where, effective drugs that happen to cost a lot are ending up in higher tiers alongside drugs that are, marginally beneficial, and things that the flip side is less expensive drugs that, aren't particularly useful or ending up in lower tiers. But, we're a long way from these P&T committees driving this sort of value-based kind of approach. But yeah, there's that kind of management going on. It's much less in the doc's office still. Then partially because of lack of tools. Rena's alluded to this burgeoning industry of using the electronic health record as a way of managing care and having things like prior authorization in place for these ordered drugs in physician offices. But I think we're just on the cusp of it. And in full disclosure, Sloan-Kettering's involved with one of these processes with IBM Watson. But nevertheless, I don't know where that's all going to come out. And the P&T committees, again, will be looking to that kind of resource. Say, okay, you manage this because we're not going to be able to do it.
Got it. Cynthia, I'm sorry, go ahead, Rita.
So the only other thing I would add is that we keep on switching back and forth between the infused and the injected drugs and the oral drugs. I think the processes by which we evaluate value for the oral drugs is going to be very different than for the infused and the injected. The oral drugs are going to be much more open to pharmacy benefit managers and the other types of kind of command and control mechanisms that insurers are comfortable using for other oral drugs like antidepressants, where you'll see first tier, second tier, third tier.
Rena, let me stop you there for a second. Just again to level set, there are really two worlds of drug reimbursement. There's what's called the pharmacy benefit, and that is that 15% cost that I showed in the first slide. And then there is the medical benefit. The medical benefit includes many of the infused drugs. Very few of those actually go through the pharmacy benefit because of the way they're paid. In fact, many insurers don't actually know and can't specify which drugs or the cost of the drugs that are put through the medical benefit side. That's what Rena's referring to here in these two worlds. And I think you'd probably agree that most insurers are trying to take the specialty drugs, as many as they can, and throw them into the pharmacy benefit where they have much more many more significant controls. They can do things like tiering, which they're not allowed, which they can't really do on the physician side, on the medical benefit side. Is that right?
I think that's true, but also that there provides an incentive for manufacturers who anticipate that they're going to have to demonstrate value, and also they're going to have to go through the kind of ringer of pharmacy benefit managers to raise their price. So they can raise their unit price knowing that they're going to have to provide discounts and that they know they're going to have to negotiate with P&T committees and others to actually get on the formulary in a reasonable placement.
Cynthia, what's your thoughts on this?
I'd actually like to comment on Rena's last comment in terms of anticipating what the expectations are going to be. I think in the injectable space, really the hurdle has always been the FDA and getting a differentiated label from the FDA. I think the question is for companies now looking at putting a product in the market in 5 years, what are they going to have to do to ensure not only the FDA approval, but also to get through the hurdle of the tech assessment committee or the P&T committee, or what Medicare will require in order to get the drug on the market. And that really changes the dynamic a lot, and because it's not well defined, as we've discussed, I think it's difficult, and I think it's something that people investing in a new product early on need to start thinking about.
Cynthia, can I come back to you for a second? One of the interesting things about Affimax is that its ESA was positioned differently to investors when Affimax began than subsequently, particularly after the federal government decided to change the way it was going to pay for ESAs. Was that a good thing for you all or a bad thing for you all relative to your competitors?
That's a really interesting question. I mean, I think, if you launch into as we discussed, this ASP +6 market, it's traditional and you compete on a variety of things, and one of them, many times is not necessarily on the cost effectiveness of the product. When you launch into the bundled space, you have an opportunity to compete on value of the product, on not just cost, but also on operational efficiency of the product, and other things that the product can offer the provider. And I think that we were up against a very entrenched competitor, and I think it offered us an opportunity to compete in a way that we wouldn't necessarily have had in the traditional reimbursement world. So while the market for ESAs and the use of ESAs declined as a consequence of this bundled environment, right? Because providers were trying to reduce their costs. Overall, I think it can be perceived as a very good thing for a new entrant to have the opportunity to compete.
And to compete particularly within a bundled environment by showing that you can actually be economically more effective for companies that are going to get paid essentially, for groups that are going to get paid a fixed fee.
Right. Across all value, economics, operational, and there are a number of things, but I think it was a very unique launch strategy that allowed us to try something different in a new environment.
If you guys were at drug companies and you had a choice, you could go with a drug that was going to be self-injected or oral, or you could go with a drug that was going to be infused. Next year, you're going to get this approved. This is a magic development program. What would you go with? Peter? You're a drug company now.
Something that could be administered through durable medical equipment. Because no one's ever going to get to that space. That's one of the last bastions where you can be reimbursed based on the published average wholesale price. So it's mostly populated by generic drugs right now, but that's what I would do.
Not a good answer. Rena?
Oh, no, I do. Well, I like that answer. There are companies in the space that have very long-lived products because they figured out both how to own the product itself and the patent of the chemical entity, but they've also figured out how to own all of the equipment around the entity, even after generic entry or after patent expiration occurs. So I think of Baxter as being a really interesting company in this space because they clearly have innovated around the whole product line in perpetuity. And once you buy the Baxter set of infusion, you're locked in for a good 15 to 20 years. I think that there's opportunity in the oral space. I think that being first in class is going to be really important, because there you have both, you're going to demonstrate value by simply existing and getting through FDA approval, and you're also going to have competitors enter, but they're going to enter much later, hopefully, and you can have the patent fight on the other end about whether you're going to be able to fight off patent expiration over time.
Cynthia?
Goodness. I still think the injectable and infusion space is probably the most interesting from a drug development standpoint in this market, in this payer market still. But I would say that your comment about patents made me think about the potential entry of biosimilars in a few years, which may change that dynamic somewhat as well. And we haven't talked about that yet. But there's not a pathway defined yet. But I know the biotech community has been very focused on how that will move forward and what impact that's going to have on injectable drug pricing.
Let me just make sure that you all recognize, if you would like to ask a question, please ask a question. There are microphones that you can just do it, please.
Many drugs that are infused are oftentimes large volume drugs, or biologicals, if you will. And many of the developments that are occurring are oftentimes in the biological space, although I'm not sure that small molecules at some point won't come back. So I really asked the question from the viewpoint of the setting where the drug is delivered. And the reason I bring it up is because there's this big move to out-of-hospital treating of people, theoretically cheaper, and I suspect in reality cheaper. And so I wonder how that gets into the equation, the setting in which it's done, and the fact that many of the drugs are biological. So I wonder if you could maybe morph those two into some common answer or comments.
Can I ask you to clarify? So in the physician office, there's plenty of sort of infusion capacity where large molecules can be given. So are you distinguishing between the hospital, let's say outpatient department, which are part of hospitals, as opposed to the physician office? Or you're distinguishing between infusion settings and sort of take-home pills?
Well, I'm going further because hospitals are actually buying physician practices and home health practices. They're moving out because you don't want to have a person go back into the hospital. That's very expensive. So this move is very real, very large, and that would tend to favor, well, not necessarily favor a biological versus a pill, but a person taking a pill and controlling it, it's one thing. Infusing it is a different thing. So I'm really, the two questions. One is the movement toward biologicals as effective drugs, whether in fact that is the case. And second, where is it given? Because this cost equation has to do with the hospital charge as well as a non-hospital charge, and there's a big difference between those two. So it's two questions, really, biologicals and setting in which it's given.
So it's clear that there's been a shift in infusion services that have gone from the inpatient setting to the outpatient setting. There are a variety of reasons for that. One has to do with bundled payment that's coming through healthcare reform to the hospital. Hospitals are very squeezed right now, and so they want to get outpatient, they want to get patients who are inpatient in the outpatient setting. There are also some other policy drivers of that. There is discounts that manufacturers are required to give to certain types of hospitals in the outpatient setting.
Really?
If they're covered by Medicaid. Those discounts are non-trivial. We're talking 30 to 50% off of list price for drugs delivered in the outpatient setting. We saw this in the biological space in 2000, I think early 2000s for blood products. We're seeing it now in oncology products and others as well. I don't, so I view that as being, it's the hospital's interest to gain those discounts, and it's the hospital's interest to kind of shift things into the outpatient setting if they can. But I don't think that that has anything to do with whether it's oral or infused. It has more to do with whether you're going to get
There's
the
two
markup.
questions, really. One is many of these expensive drugs are oftentimes biologicals. And if that is a persistent trend, and you'd have to answer that whether it's persistent and real or just fictitious, what effect will that have on the pricing, the large, what do you call it, biologicals versus small molecules, and what trends might be occurring there, because that impacts your cost equation considerably.
Sure.
I think it's a difficult call whether or not the sort of next set of products will be dominated by small molecules that can be delivered through a pill on the outpatient side versus infused. I think it's hard to read the tea leaves on that. If you look at the recently approved drugs by the FDA, they sort of are in both buckets. Certainly examples of precision medicine targeted to particular driver mutations that come in pill form, also infused. So I wouldn't want to make that call. Both. And there'll be high prices. There have been very high unit prices in both buckets.
Because they're $100,000 for a biological is not uncommon nowadays. I don't think you'll see the same thing as much in a small molecule pill.
Oh, no, you absolutely do. They track pretty well. And if you sort of standardize to monthly or standardize to a course of therapy, the prices just for the agent, are sort of well matched. So, $5,000 to $10,000 a month for a standardized size adult.
Thank you.
Other questions? Wendy?
So my question is, this panel has really two questions, but one is this panel has started at the beginning mentioned ACOs, but hasn't really focused on ACOs, and I'm just wondering how you see those evolving and to what extent they will be influential, and our hospitals and providers quick to take on risk.
So the question is, how will ACOs evolve? And I guess since most ACOs have at their center a hospital or hospitals, will those providers be equipped to take on risk? Rena, you're the most academic of us here. You probably have studied this.
So I sit in a hospital where just recently I was sitting in my section chief meeting where we were told that our little section of oncology is interested in becoming an ACO, and I just had to laugh. Healthcare reform is coming. Hospitals and medical groups are in talks either to become an ACO or, I think more likely, create affiliations with existing insurer groups or get gobbled up in its entirety by existing insurers, in part because the average hospital exec doesn't really have the tools or the resources at their disposal, or frankly the budget to really manage the risk that we're talking about at a per population level. I think the thing that's most interesting to me is that physician specialty doctors are now talking very seriously about getting out of being entrepreneurs and becoming employees of the hospital or of the medical group or ultimately of the insurer. So it'll be interesting to see how that drives choice of treatment. It's clear that when you become an employee, you have a lot less say on what you do. And your employer has a lot more say.
But you have better hours, right? That's there. So that
no call.
Right, no call, right? So you get a hospitalist, and I think the prediction, a reasonable prediction, would be that the ACO construct, which has actually had many different manifestations, from highly integrated risk-bearing entities, which are sort of willing to take risk up and down, to kind of intermediate versions of that, to things that really look like fee-for-service masquerading as an integrated delivery system, where sort of if they win, they win, if they lose, they didn't lose anything kind of structure. I think, you know, it'll be a non-trivial segment of the market in the next 5 years that starts branding itself as ACOs. If you look at the places where ACOs have cropped up, and there's various people, the Dartmouth-Brookings collaboration tracks this. You can obviously look at the Medicare entities that are involved in various demonstrations, both through CM and CMMI. And there's special kinds of marketplaces that don't look like, call it 80% of the US healthcare delivery system or environment, right? There are places like Boston, we'll never have it in New York because this is a highly competitive place. So I think the challenge in the specialty drug space is getting the incentives right from a top-down structure. And I alluded earlier to this idea that these ACOs, if they really want to sort of reduce total spending, they're going to have to bring in knowledgeable intermediaries. And the reason is basic economics. If you look at these high revenue, high spend specialties, like I'm a pulmonologist, but in oncology, or I mentioned ortho, invasive cardiology, invasive radiology, these are places where so much revenue is generated or so much money is spent so quickly among so few patients, and the sort of profitability opportunities are so large that it's going to be very difficult from a top-down approach to manage down into those little silos where all the money is being spent. And so it's sort of this interesting idea, you know, you have 1,000 primary care doctors who, if they manage diabetes a little bit better, at the end of the year they'll get a check for $23. And then they look at an oncology practice, an orthopedic practice, and say, now you behave too, and we'll give you $23 also. And so the over-under for some of these specialties is just extremely unattractive compared to sort of doing what they're doing now. And so we're going to have to see, I anticipate we're going to see carve-outs more, particularly on the government side. They'll say, well, we're not going to look at this sector of spending, but let's look at the gain share around prevention, primary care kinds of conditions.
And just to chime in on my own point of view on this, there are already dozens of companies starting out to help manage ACOs and to get in on this business. Steve Wiggins, who started Oxford Health, has got a very interesting new company out, which is going to do episodes of care at, I think it's like around 20 of the very largest hospitals in the Northeast, basically carving out high-cost areas of this.
Right.
Every single insurance company, every single major insurance company is trying to get into the ACO business. It's not exactly true, but Aetna, for example, I don't mean to say that Aetna is going to do this, but basically, if you look at what Aetna is saying, 1/3 of its profits by 2018, it says, are going to come from non-traditional insurance business, non-traditional, non-insurance businesses, which is to say, I'm going to get into the provider world, I'm going to get into the ACO management world. So
medical record business.
Medical, right. So fundamentally, I don't think this, whatever we say, we are going into a risk-sharing environment. Whether it's the actual, whether Yale New Haven is in fact going to be successful at being an ACO, I don't know, but somebody is going to be successful, and that means that my part of Connecticut, where I live, is going to somehow be under a risk-sharing environment. Harvard Pilgrim has got now a couple of ACOs, including specialty, including an oncology ACO going. It's just not, I think this is a juggernaut that is not possible to stop.
CMS just announced last week that it would allow ESRD providers to become ACOs, and the two largest dialysis, the two largest dialysis providers actually had run ACO demonstrations prior to that and done, had a very successful time with it. If you can imagine, they're caring for very expensive patients. They're seeing them 3 times a week. And they have the ability to intervene in their health care in a much broader way than just dialysis care. But I think it'll be very interesting to see how, if they do take risk for hospitalization costs, how that changes incentives around how they treat patients, how drugs are considered. Right now, if you can imagine a patient who's in the hospital also under a prospective payment system doesn't necessarily get treated for some of the conditions. Drugs aren't used in the hospital. They wait till the patient gets back to the dialysis center, and the care isn't as good as a consequence. So once all those costs come together and all the outcomes responsibility and the cost responsibility is really shared, I think patient care can also improve in that environment.
But I can also, just one quick example of something that I think will change. Right now in the cardiac cath lab, if you go in you have to have some kind of anticoagulant therapy, you might get a drug that the manufacturer gives the hospital a great price on, because he knows that after that patient leaves the cath lab, he has to stay on that drug. One good example might be Effiant versus Plavix. If you go in and the hospital has gotten a great price on Effiant because Lilly knows that giving that drug at the hospital means that that patient will stay on Effiant pretty much for the rest of his life, as opposed to Plavix, which is generic. That kind of thing could change fairly dramatically if the ACO is responsible not merely for the inpatient side of that cardiovascular issue, but also the outpatient side. That's one of the things that I think is going to be a big change.
Sorry, Peter. No, first of all, that sounds like a kickback. But so there's an interesting tension here, and it's sort of in the weeds about whether or not this sort of where the risk is going to sit. And if you think about patient populations, the legislation around accountability. The word accountable, I think people have already forgotten this, refers to accountable for a population. Right? So the idea is ACO is sort of a neighborhood provider, and everybody who lives there, sort of this thing that sits on the hill, is taking care of them, from primary prevention to end-of-life care. The term has gotten stuck on other things, but the key distinction here is between place on the hill taking care of a population for everything and highly siloized, kind of episodic, people with particular conditions, payment flowing, where risk for things are sort of extending beyond the walls, right? So the dialysis situation, okay, maybe hospitalization gets wrapped in there, maybe infection management or things like that for around the catheter, or oncology, bundle payment within oncology, or the BPCI demos, the orthopedic procedure in the next 30 days. And so there is a division in the healthcare policy community regarding which approach will be more effective, which one will sort of protect patients more, and sort of which one at the end of the will carry the day. And so the primary ACO idea was place on the hill, and all this other stuff you're hearing about, which I think will carry the day, because these pathway companies and Wiggins' group and stuff like that are focused on these highly expensive, siloized, like the patient gets in when they have the condition kind of approaches.
So the only other thing I would add is we have lived through part of this history before, which is in the mental health sphere, costs were going in double digits in the 1990s. What did insurers do? They carved them out. They carved them out to specialty providers who could get people out of the hospital, which is where all the money, most of the money in healthcare is spent, and into being managed in the outpatient setting. What happened to drug spending? It grew a lot. Why? Because physicians weren't incented to control the pharmacy costs. Instead, they basically got them out of the hospital or out of the office quickly and gave them a prescription and sent them on their way. So it is possible that as payers really clamp down on reducing hospital costs, we could actually see a demand for drugs, particularly, again, oral drugs, but others as well, and in the infusion suite actually increase over time.
I am afraid we are out of time. In fact, we are 1 minute and 7 seconds over time. I apologize. So listen, thanks to my panel, and thanks to you for listening to us, and we'll see you all later.